Hi, welcome to this 20-minute slot on assessing for post-traumatic stress disorder and complex post-traumatic stress disorder. I'm Hugh, I'm a principal cognitive behavioural therapist, and I was asked to help develop the intervention framework for PTSD and complex PTSD. I started working in the NHS with care experienced young people in 2010, principally in psychodynamic and attachment kind of focus ways, and then evolved into EMDR and cognitive behavioural therapy in the last sort of 8 or 9 years. So yeah, what we'll cover today is what the definitions are, what moderate to severe needs look like, what our framework looks like, questions that can help with assessment, effective use of the CRIES-8, which is a sort of standardized measure we use for assessing PTSD, and then also a bit about differentiating from the difficulties. We're going to bring in an interview with Richard Miser-Stedman, who's one of the leading clinicians and researchers in the field of complex PTSD, and also massive thanks to the National and Specialist team and the UK Trauma Council who've helped us develop this framework. Richard, thanks very much for joining us at Sussex Partnership. Would you mind just introducing yourself quickly?
Hi, Hugh. I'm Richard Miser-Stedman. I'm a clinical psychologist and professor in child clinical psychology at King's College London.
And you've worked extensively with PTSD and done a lot of research into trauma. Is that right?
Yeah, so I started off doing work with children who've been involved in sort of single one-off traumas like car crashes and assaults. And over the years, I've worked more in the area of children who've been involved in sort of recurrent or multiple trauma exposure. Yeah.
Thanks, Richard. So just we're familiar with the terms complex trauma and developmental trauma and also complex PTSD. Can you provide some clarity on these terms and sort of effective CAMS interventions when we know that a young person has been through several traumatic events or experiences?
The terms developmental trauma and complex trauma are used a lot. And I think that the sort of scientific literature would certainly recognise that multiple traumatic experiences in childhood can be bad for development. I mean, that's a fairly obvious sort of thing. I guess sometimes there's there's been a move towards talking about developmental trauma or complex trauma as a sort of diagnosis in their own right. And that's where the sort of science doesn't really kind of follow on or match up. Well, there's certainly quite a lot of debate around that still. And I think what my colleagues and I would suggest is that really after some sort of repeated trauma exposure, young people really need sort of thorough and careful assessment. And we can't assume that if they've been involved in sort of recurrent or multiple trauma, that they'll definitely get one sort of set of symptoms. There's often a wide range of mental health outcomes that can occur. PTSD is certainly one such outcome. And in the latest version of the ICD, so ICD-11, the World Health Organization's sort of guidance on diagnosing mental health and physical health conditions, what they've done is differentiate between sort of PTSD on its own, so re-experiencing avoidance and a sort of sense of threat, and complex PTSD, where you have all those symptoms, re-experiencing avoidance and current threats, as well as what they call disturbances in self-organization. So that's problems with self-concept, a very negative self-concept, problems with affect regulation, so very angry, very overly emotional, and also problems relating to other people. So it's the presence of those additional symptoms denotes the presence of what's now called complex PTSD. And this is we're still sort of gathering data on this condition in children and young people.
And as CAMS clinicians, we know we've got to get better at assessing for complex PTSD whilst listening to some really distressing experiences from young people. And in our trust, we have 3 questions that we ask. We're encouraged to ask. Can I just let you know what they are and then hear your thoughts?
Absolutely.
So the first is, have you ever experienced a difficult event which still significantly affects you now? The second is, do the memories come back frequently without warning, causing strong emotions? And the third is this a problem you want help with now? What do you think of those questions, and what other steer might you give us on when it comes to assessing the complex PTSD or other other difficulties after hearing about trauma?
I think those are fantastic questions. In our experience, children and young people can come to CAMHS and they aren't really always given the opportunity to talk about the traumatic experiences they've had, and some sort of more careful follow-up, even though just the next two questions you asked around what memories is, do you have any intrusive memories, and is this something you want help with? Those questions may not be asked either, and that's such a shame. In the CRIP trial, a study we conducted looking at PTSD after multiple traumatic stresses in children and young people. This was in CAMHS across England and Wales. One of the things that came out strongly in the qualitative interviews we conducted was that children were quite frustrated that sometimes they would disclose trauma, and then no one would ever follow up on it and sort of give them the chance to sort of seek help or see if they wanted to have some therapy sessions focused on it. So I think giving children that opportunity to say what they want, to say that it's causing problems, and to say what they want, I think is absolutely crucial. And so I'm delighted to hear that you're asking those things, to be honest. I think asking those questions, I think, can be quite daunting for clinicians. I think clinicians can be very worried about what they're going to unpack, and are they going to somehow make things worse. There can sometimes be a lot of sort of discussion around re-traumatizing children or teenagers by any kind of discussion of trauma, and I really worry about that kind of idea, really, because if we get too worried and too hung up on those sorts of fears, then actually we're denying the children the right to talk about their experiences, and that's so invalidating. There's so much good care that we can offer these children. It's such a tragedy, really. And of course, sometimes it can be hugely reassuring for the family, carers, to hear that actually, after your assessment, a child is doing okay. Sometimes people assume that any child who's been involved in something really horrible, even if it's repeated, there's an assumption that they're bound to have a mental health problem such as PTSD. And it may be that they're doing okay and that the symptoms are very mild and don't really need sort of particular treatment. So gathering data, doing a proper assessment, it's really seeing what things are like. It's so vital.
Thanks, Richard. Any pointers on really helpful things you've learned over the years when it comes to assessment, from your personal experience or your supervisee's experience when working with particularly maybe younger or more distressed young people?
Yeah, so in our research, we've done sort of hundreds of assessments over the years, and it's unusual, really, for the assessment to have to stop or something like that. Now and again, we might need to have breaks and things, but we just try and do the clinical basics well. Put a child in control, empower them, let them know what you're doing and why, work at a pace that's appropriate for them. And we've generally found that the assessments go okay. With slightly younger children, of 7, 8, 9-year-olds, we'd be confident about doing an assessment with them. We think they can do this kind of work okay. Again, I would trust your judgment, about kind of sort of how much you adapt the questions to their developmental level, but probably don't need much adaptation, if at all, really. Often, they get typically they would get the questions that we're asking around, say, traumatic stress symptoms. That I think they'd be able to put that into words, and I think it can be hugely sort of validating and reassuring that when you ask them a bunch of questions and they realise, oh, actually, I'm not the only person who's ever felt like this. So we've found work with that age group to be fine, really.
And we know from Rosie McGuire and others' research that care experienced young people are still being really underserved by CAMHS. What should we be doing better?
I think it's still a problem at sort of system-wide level, really. And so having the discussions in your teams about these children is really important, and feeling comfortable about asking those specific questions that some of those specific questions that you mentioned earlier. Not being afraid. I think with these children who are care experienced, there is a sort of a particular anxiety about asking about what they've been through. And yeah, this is just such a shame. We know that these children are vulnerable to developing post-traumatic stress. Not all, but certainly a significant minority will develop difficulties like that. And they very much deserve care, and that's evidence-based. So I think asking the questions, doing the assessment still with that population is so important. Yes, sadly, I think we are still at the stage where there's a sort of system-wide avoidance, really, about having these discussions with children, and I think it's wrong. I don't think it's really borne out by the evidence. I don't think there's any evidence of harm yet or anything like that from doing these assessments. Again, some children might be distressed. I think it's something that can be managed, and if they are distressed with something, this gives an opportunity for learning and seeing what's going on, and using that information to inform what work happens next. But yeah, so often these children are kind of deprived of the opportunity to really sort of work out their whole life story, the whole understanding of what they've been through and who they are. So it's a real tragedy, and I think we need to be sort of challenging the story on unusual practice on this work. I think we can be more focused and trauma specific. Yeah.
And just to finish with some hope, the evidence-based treatments for CPTSD are pretty effective. What have we learnt since the last NICE updates about them through research?
So there was a sort of recommendation for trauma-focused CBT in the 2005 guideline, and NICE guideline for PTSD, and then in the 2018 guideline, where there was probably at least sort of 40, 50 more clinical trials, the evidence just grew much stronger in favour of that kind of way of working. And recently there's been several reviews that suggest that children involved in single incident trauma do well with these kinds of therapies, but so do children who've been involved in multiple traumatic experiences. In fact, there's more evidence for the treatment of PTSD in children who've been involved in multiple traumas than there is for single incident traumas. I think sometimes people think, oh, the evidence for trauma-focused CBT only relates to, say, single incident experiences. Yeah, that's just not true. So the evidence is now really very clear that these are evidence-based ways of working with PTSD, using something like trauma-focused CBT, cognitive therapy for PTSD. They're all the same sort of thing, really. But yeah, the evidence now is very clear, and the tragedy is not enough children get those sorts of therapies, really.
Richard, thanks very much for your time, and yeah, thanks for all your incredibly valuable work on complex PTSD from all of us at Sussex Partnership. So don't want to repeat too much of what Richard said, but just to go through the basics. PTSD, as we know, really common reaction to traumatic events, where someone feels frightened, helpless, or horrified. So things like being assaulted, sexual assault, severe accidents, witnessing someone die, or experiencing domestic or physical abuse. Thankfully, only about 1 in 4 young people who go through such experiences develop PTSD. In actual fact, more young people develop depression, so it's really worth bearing that in mind when we're hearing about traumatic events, that it's not just PTSD that's the given outcome. And as Richard said, complex PTSD, it could be from a single or multiple incidents, but it's about the additional symptoms of interpersonal disturbances, negative self-concept and affect, emotional dysregulation. Some of the challenges are that very few of us are regularly identifying PTSD and complex PTSD, and I count myself in that cohort. It can be very challenging to correctly identify. Care experienced young people are twice less likely to get help. And moderate to severe complex PTSD will include, it's very likely to include relational and self-concept difficulties. So it makes it harder to tease apart from other difficulties such as emotional intensity. And as assessors, we know we can we can really get hit hard by the traumas we're hearing rather than focusing on the current challenges. So those are some of the challenges we face. To reiterate, the questions we're encouraged to ask in Sussex Partnership are: the first one, have you ever experienced a difficult event in your life which still significantly affects you now? And you can ask that any which way feels comfortable to you, and it might be worth just practicing what feels right to you in terms of getting that question across. If that comes back with a yes or a yeah, then we move on to the next two. So do memories come back frequently, unbidden, without warning, causing you really strong emotions? And if the answer to that is yes, then is this a problem you want help with now? So you can ask those questions any way you want, but they're the key ones. If you get 3 yeses, then we'd encourage you to ask around the headlines of what they're talking about when they're talking about those memories coming back. So would it be okay to ask a few more questions about how those memories are affecting you now? Would be a nice way of segueing into that. You don't have to answer anything you don't want to. Could you give that horrible experience a label? We're asking them just to try and come up with the headlines of what happened rather than unpacking everything with us in an assessment. That's not our job. We don't have to go that far. And if we've got some headlines, we can move to the CRIES 8, which is a really helpful tool. So the CRIES 8 is 8 questions, and it helps measure the amount of avoidance and the amount of intrusions a young person is experiencing. And as we're asking the young person these questions, we're not wanting to do lots of validating, empathizing, and normalizing. So saying things like, I'm really sorry this has happened to you. You're not alone. These kind of traumas are really more common than we'd like. That's a really horrible but understandable reaction, and giving hope as well that there is a treatment that works well. There are treatments that work well. So empathize, congratulate, and instill hope. The treatments are highly effective, 70-80% effective. The most effective form of CBT is trauma-focused CBT. EMDR is also highly effective as first-line interventions. Avoidance and intrusions are very normal reactions. You could do the scoring on the CRIES 8 together. So 17 out of 40 is the cutoff point. For moderate to severe, we're looking at sort of 25 or over. Just be mindful that it's not a cut and dry CRIES 8, and you can have someone scoring really high, but actually if you haven't dug into it enough, you haven't had time, it may be that rumination is going on and they're actually depressed. So whilst they're reporting that they're distressed a lot by the events, it may be that they're just thinking about them a lot rather than having intrusions. You could watch a video together. There'll be a 1-page resource that will help you with lots of resources and videos, or you could share the PTSD guide for parents and carers. And just always keeping in mind, it's a working hypothesis we're coming up with here in assessment rather than a formal diagnosis, obviously. In terms of differentiating PTSD, complex PTSD from, say, ADHD, when we think about the hypervigilance, or emotional intensity, when we think about the affect dysregulation, or depression, or anxiety or panic, it's really worth using consultations and MDTs. But most importantly, really keep the young person's view front and centered. It's what they want help with that matters most with assessment, and that's no different with CPTSD. Yeah, so in terms of the guidance that's informed the framework that names trauma-focused CBT and then EMDR as the frontline interventions, that's links to all that is here. And I'm just going to round off by giving you a vignette to see if you can spot the identifiers for complex PTSD within this. So this is a vignette that went out as part of a research project in 2022, and it identified that CAMHS clinicians find it very hard to identify complex PTSD. So have a read of that, press pause, and then I'm going to, a bit like the football results, I'm going to sort of outline where the markers are. So if you have pause and press pause, go through it yourself if you've got time. If not, I'm just going to go on now to talk about the identifiers. So here are the identifiers. So firstly, we can see straight away, okay, there've been traumatic events, violence at home. So unfortunately, Connor has probably experienced some very significant traumas. We know he's safe, which is great. Difficult to get along with, rarely happy, quick to anger. So there may be some affect dysregulation there, and interpersonal difficulties. Can take hours to calm down. So this is someone who might be hypervigilant and really struggling with their affect. Spends a long time of periods at home, so interpersonal difficulties perhaps, finds it hard to stay on task or concentrate. So someone might think, oh, is this ADHD? But it might also be just their arousal system is very activated and they're really struggling to calm themselves down and be in a place to be able to access learning. Sleep is very poor, so possibly he might be having nightmares or be worried about having nightmares with intrusive memories. So that's quite common if people don't want to go to sleep because they're worried about the nightmares and they can't get back to sleep when they're having nightmares. Doesn't want to talk about what happened in the family home, so avoiding that, very common. Freezing up, again, getting activated and possibly dissociating if asked about the events. So yeah, and we know that PTSD doesn't get better unless people are helped. So the fact that it's been issues for a few years and getting worse indicates that it may well be PTSD. Yeah, so that's a bit of a very whistle-stop tour of one vignette that a lot of counsel clinicians struggle to identify PTSD within, and some possible markers within it. So I hope this has been helpful. And yeah, please do email me if you would like any further pointers or guidance. My email is hugh.miller3@nhs.net. And yeah, thanks very much for joining us.